Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks everyone for having me. So as Hillary said, I'm here today. I was charged with giving some updates on Mpox. And I was just reflecting that even when Brian and Hillary had reached out to ask me to do this a couple months ago, we've had a lot of new information, especially in the last week or so. So we'll dive into that a little bit. I have no disclosures, just the usual disclaimers about brand names, and healthcare disparities do come up in this talk. And so I just want to particularly call out that racism, not race, creates and perpetuates those disparities. So when I was thinking about how to frame the idea of Mpox in 2024, there's so much that we know and still don't know. And so I really wanted to hone in on, I think, some areas where I think we've seen some updates and that are going to be relevant to us if we do, and as we do, continue to see Mpox. So I'll start with some epidemiology updates. We'll talk briefly about clinical manifestations, treatment, and then vaccination as prevention in particular. And a lot of this talk is derived from talks I've heard from a colleague over at Columbia, Dr. Jason Zucker, who's also my co-author on the National STD curriculum page on Mpox. And he gives a lot of these talks, and I really like this slide he has that shows us how Mpox knowledge has expanded rapidly in the last years. And so you can see from 62 to 2002, there were 9 publications a year in PubMed on Mpox, then 36 a year, and then all of a sudden it exploded to 158 per month, mostly driven by Clade 2B, so this current 2022 to now outbreak, left fewer than 200 results specific to Clade 1. So I think as we were doing our literature reviews for the curriculum and thinking about how much literature is out there, there is just so much, but still so much more that we need to know. So with that, let's move to epidemiology. So I'll just quickly review what we knew prior to 2022. And so many of you have heard this, but Mpox virus was first identified in the 1970s in West and Central Africa. It was associated with animal host exposures. And we knew about 2 clades of virus. So there was Clade 1 that's associated with more severe disease and is more transmissible than Clade 2. Previous US outbreaks, so what I got tested on my infectious disease boards, were spillover events from imported mammals from West Africa, or in some cases they were travel associated, but there was no subsequent chain of transmission in the United States. So what was different in 2022? As you all recall, there was this huge multinational Mpox outbreak that was driven by Clade 2, and in fact Clade 2B as a subtype. There were 97,821 cases thus far as of June 12th, 2024, in 118 locations. Only 7 of those locations have historically reported Mpox. So really the majority of cases were epidemic, non-endemic transmission. What was really novel is that this was human-to-human transmission, the majority of which was occurring via sexual networks. And as you all recall, primarily men who have sex with men, although not exclusive to that population. Other forms of transmission that we've talked about are fomite to person, so can objects, clothes, transmit? Yes, not the primary mode of transmission. Respiratory transmission is not a settled question, but again, not felt to be the predominant mode of transmission. And so it's not sex per se, but very close, intimate contact. That's been that mode. And what about the United States in particular? More than 32,000 cases from January 2022 through January 11th, 2024, which is when the CDC stopped updating their nice epi curves on their website, although they are still reporting weekly cases by state with a little bit of a lag. So what you can see is that really remarkable peak in cases. And I'm asking you to pay attention to the y-axis of this graph because I'll show you what's going on now. And the axes are quite different. But you all recall that in the summer of 2022, we saw this really huge peak. Not a high mortality rate. So thus far, 56 Mpox-associated deaths, so a case fatality rate that's quite low. But what's important to note is that it's disproportionately affected certain populations. So men who have sex with men, among cases reported at the height of the outbreak, more than 90% were among cisgender men. The highest number of cases were reported in persons 31 to 35 years of age. And I think importantly, among all age and gender groups, Hispanic, Latinx, and Black persons accounted for more than 60% of cases, despite representing only about a third of the general population. Similarly, transgender and gender diverse adults accounted for nearly 2% of cases in the US, despite representing only about 0.5% of the population. In terms of concomitant infection, 40% of those diagnosed with Mpox also had HIV. Another 40% had also been diagnosed with a reportable STI in the previous year. So what's happening now? A few things. I wanted to highlight my two favorite cities, or the two cities I know best in the US. So among King County residents, you can see these epi curves from public health, that you see this peak in July 2022, and then you see this pretty remarkable drop off in cases. And then in the fall of last year, you see a little peak or blip, something beyond a blip, where you have that 9, 12, and 9 cases. And so there have been these kind of cluster outbreaks in King County. And similarly, in New York City, there was a health advisory that came out, I got the email in May, that looked at New York City cases and said, again, similarly, case numbers were relatively low for most of 2023, about 2 to 20 cases per month between January and September. But then in October, there was an increase to an average of about 36 cases per month with a peak in January 2024. And again, I want to note that among those New York City cases, the majority of individuals were not vaccinated or incompletely vaccinated, meaning only one dose of Jynneos, which we'll talk about. 94% of the cases were among men who have sex with men. The majority were in Black or Hispanic, young men between the ages of 25 and 44, but most cases were quite mild. Only 10 or about 4% were hospitalized. And again, I told you to pay attention to those y-axes on the CDC epi curves, and that's because countrywide, I think you can see that there is this low-level circulation ongoing, but it's nowhere near the peaks of summer of 2022. So you can see now this is weekly data, cases that are closer to 10, 15 tops, but that's dropped off. And you can see that pretty steep drop off closer to now, but there is a lag in reporting time. So I wouldn't be surprised if that's actually higher later on. And then the other thing you might have all seen in the news is an Mpox outbreak in South Africa. So this is very recent, that from January to really June and ongoing, there have been 7 confirmed Mpox cases that have been reported that importantly are clade 2 and involve men between 30 and 39 years of age, all with HIV. 5 of the 7 reported, or we have data that they are men who have sex with men. These cases have been in multiple provinces with no international travel history in these men, and unfortunately 2 deaths. And what we don't know if these individuals were vaccinated. This wasn't reported. The presumption has been that they were immune compromised with respect to their HIV, although from what I could find, that was not being officially reported by the African CDC. And so I think that's something we'll hear about more, hopefully, in coming weeks. And I've been making this differentiation between clade 2 and clade 1 because what you also may have been hearing about is the clade 1 outbreak that's ongoing in the Democratic Republic of Congo. So since January 2023, there have been more than 12,000 suspected cases of the more severe and transmissible clade 1 Mpox. You'll notice that higher mortality rate, so 5% case fatality rate rather than the 1% we've been seeing in clade 2. One cluster was associated with sexual contact, which is the first time that's been described with clade 1 virus. There have been no Mpox infections due to clade 1 that have been reported in the US in this time frame. It is something to consider in a patient with a clinical illness who has been traveling to overseas, and vaccination is expected to be protective. There is no difference in management or treatment options for clade 1. So again, something that's ongoing, and I think a real call to attention to what's going on in endemic spread and epidemic spread outside of the US and Western Europe, which has been one thing that we've really thought about with respect to equity in Mpox. So I'll switch gears now to talk about clinical manifestations and really just highlighting what's been different and what are things we might want to think about. So I'll start with what we thought of as the typical presentation in the 2022 outbreak. So we thought about the rash. That was kind of the characteristic thing that we thought about with Mpox, with this evolutions from macules to papules all the way up to crusting and healed. We knew that those phases could occur at the same time. So you could have someone who had crusting and vesicles at the same time, for example. This was often associated with a prodrome that patients may or may not have remembered, of fevers, myalgias, almost a viral illness kind of syndrome. And then a lot of really terrible manifestations with respect to what patients were experiencing beyond the rash, which in and of itself might have been quite disfiguring, but anorectal symptoms like proctitis and rectal pain, bleeding. oropharyngeal symptoms like pharyngitis, epiglottitis, tonsillar lesions, ocular manifestations like conjunctivitis and keratitis, pain. And I say that because I think it can really encompass a lot of these syndromes. People had terrible, I really think about the patients of mine who had terrible proctitis, but oral pain as well, secondary bacterial infection, and then I'm thinking about concomitant sexually transmitted infections. So what I want to highlight now, that isn't necessarily different, but something that we've gained greater understanding of, is severe Mpox. And so this is something we saw primarily in those with significant immunocompromise. And there were case reports of people with bowel obstruction from bowel wall edema from Mpox, rectal wall perforation, urethritis, necrotizing lymphadenopathy, even myopericarditis. There's kind of a whole list of odd syndromes that occurred that were quite life-threatening in some cases. And then there was a real call to attention to severe necrotizing Mpox and advanced HIV. And I wrote CD4 less than 350 because there's some global case series that describe that as our threshold. But what we really saw is it's unsurprisingly CD4 under 200. And really, as CD4 drops, the risk of these really severe manifestations increases. So necrotizing skin lesions, visceral organ involvement, sepsis, higher rates of secondary infection, and really high mortality rates, so 25%. Most of the deaths in those with HIV, as the CD4 would kind of allude to, is these individuals were not on ART. And nearly all Mpox-associated deaths in the US have been in immunocompromised. I do want to note that almost 90% of Mpox-associated deaths were in Black men. With respect to non-HIV, there have been case reports in other populations that we do kind of remain concerned about in general for opportunistic infections. So I'm thinking particularly of a case of a kidney transplant recipient who had severe disease. So these are kind of the populations where we were seeing new and more concerning clinical manifestations. And as I talk about HIV, I just want to highlight that something that did come up in between that first outbreak and now is an OI guideline for Mpox. So there is a really nice Mpox and HIV OI guideline on the website with discussion of this epidemiology and treatment and prevention in people with HIV. All right, so that was kind of blazing through clinical manifestations and on to treatment highlights. And so this is an area that is very recently changing and we don't know a lot about, but I'll tell you what I know. So I really like the way that Jason had divided this in a previous talk in treatment, thinking about supportive care versus medical countermeasures, which is also how the CDC refers to these. And I think the one thing I really want to highlight is that the majority of patients who are immune competent and who don't have severe manifestations fully recover with symptomatic treatment. What is symptomatic treatment? It's just things targeted to the symptom that the patient is experiencing. So analgesia for pain, people with proctitis using things like topical lidocaine and sitz baths. And these were all expert opinion. There was no clinical experience, as you can imagine in the beginning. And we continue to use these therapies for people who are suffering these symptoms. With respect to medical countermeasures, these are divided into antibody therapy with VIGV and then antivirals. So I think most of us are most familiar with the use of tecovirimat through an expanded access investigational new drug protocol. And then we'll talk a little bit about clinical trial, and then cidofovir, brincidofovir, and then topical trifluridine for ocular disease. And I think what's really important to remember is that we have no clinical trial data for any of these countermeasures. We have anecdotal data. A lot of people, I think, have strong feelings about what their patients experience. Patients have strong feelings about that. And we have some cohort data, which I'll mention, but there's no clinical trial data. And really, we're thinking about these interventions now more in people who have severe disease or who are at risk for severe disease. And so I'm not going to go through every one of the medical countermeasures, just from a time limitation perspective, but I do want to talk about tecovirimat. So again, as you all probably remember, this was the first line treatment and remains so under the CDC EAIND protocol. It was initially developed for smallpox. It's an antiviral medicine that inhibits the viral protein P37, which is a viral envelope wrapping protein found in orthopox viruses and Mpox virus in particular, so inhibits replication of the virus. So then the question becomes, does it work for Mpox and in this outbreak? And so I just want to highlight that no RCT data exists, but there are several cohort studies with mixed results. And I'll mention a little bit about that later. But safety data has been quite encouraging, which I think is good as we think about, are we causing harm with our intervention? So what does it mean to work? So as far as we know, there's maybe shorter duration of viral shedding, depending on the study you look at. One said yes, one said no impact on viral clearance. It may be helped in people with HIV, although again, this was matched cohort data and it's unclear at a higher CD4 count whether that's true. There was a nice paper that came out of Sexual Health Clinic and from one of our now graduated ID fellows, Raaka Kumbhakar, where the Sexual Health Clinic looked at whether early treatment helped. And the conclusion they were able to reach is it may result in more rapid symptom improvement in those with severe illness, but no impact on illness resolution. That paper also kind of talked about the experience being quite subjective. So this was phone calls to people who felt that their symptoms were improving. Doesn't mean it's not the case. Just want to point that out. And why, when we think about why do we need to know this, I'll mention this a little bit later, but I think there's does it help? Does it hurt? And so safety profile is good, but I think one thing we should think about is drug resistance, right? And so one of the questions was, I think we knew even prior to this outbreak that tecovirimat has a pretty low barrier to resistance with single amino acid changes in one gene that can cause resistance. And so this first study by Smith looked at 124 isolates from 68 patients with suspected resistance. 96 isolates from 46 patients were found to have a resistant phenotype. And most of these resistant isolates were associated with severely immune-compromised patients who had received multiple courses of tecovirimat treatment. So people who we thought really did need treatment, got prolonged courses, got several courses, but developed resistance. Resistance overall, though, remains quite low, which is reassuring. But there was another paper I wanted to highlight that did demonstrate that tecovirimat can lead to transmitted resistance. So there's a case of an individual who developed resistance on tecovirimat, and they were able to link that the resistant strain of virus was from that initial event. So just food for thought, something to think about. So that all brings us to how do we figure out whether it really works? And I think right in the beginning of when Stomp rolled out was right when the curve of that Mpox curve was dying down. So there have been some struggles to get enough people enrolled. But the idea here, this is an ACTG study looking at TPOX or tecovirimat versus placebo, randomized 2-to-1, to really show that TPOX or tecovirimat reduces time to clinical resolution. The nice thing about the way it's designed is that if people do have severe disease or experiencing severe symptoms, they can get open label drug, and there is an open label arm so that if you were to have a patient who did have severe manifestations, you wanted to get EA, IND, tecovirimat, you could also use leverage Stomp as a way to get drug to the patient. And so Jason Zucker and others had this really nice editorial in, I think, JAMA a few months ago that was kind of a plea for before we decide this works for everyone should get it and really extrapolate. We don't know if tecovirimat works. We need to know if it does. Obviously, if it doesn't work, we don't need to use it. But more than anything, if it does work, we really need to make it available and think about equity and the distribution of the drug, right? So it's still enrolling. I have all this information up here. If you just Google it, they have a website. UW is an enrollment site along with several others nationwide. And I just want to highlight that the EA IND was recently updated, which I think will hopefully move people towards Stomp, or at least it seems like that is the call, because the eligibility criteria have become more strict. So people with severe immunocompromise, so advanced HIV, leukemia, solid organ transplantation, active skin conditions that may increase risk for disseminated skin disease, pregnant or lactating, children, and then protracted or life-threatening manifestations. So mucosal involvement counts in that, body surface area involvement. And so I like this figure that the CDC put up, and the IND, by the way, was just updated on the 5th of this month, I think, so very recently. But you can see that who can get TPOX through or tecovirimat through either method, so the IND or Stomp, and then who can get it through one or the other. And so I think that is one way to make hopefully things a little easier if you can go through the clinical trial rather than going through the whole protocol, especially if you're at a site that isn't enrolled in the EAIND protocol. Okay, and then this is a approach that was developed by the CDC for treatment of patients with severe or at risk for severe manifestations of Mpox, so the people who we would think really strongly about medical countermeasures. I just like it because it's a nice flow chart to think through, and it's really focusing on, is there immune compromise? Can we optimize the immune compromise? Can we give a drug? Is the route of administration going to matter? And then if people have really severe immunocompromise, are they at risk for tecovirimat resistance? Would they benefit from an additional agent to help with that? And because there's some in vitro synergy that I didn't discuss today between the other antivirals, brimcidofovir and cidofovir, with tecovirimat, what is the involved site? And so I think these all together give us a little bit better of a guidance of how to approach a treatment. Okay, so I'll end with prevention. And I'm specifically going to talk about vaccination as prevention. And I don't want to undermine how much behavioral preventative measures from the communities affected really mitigated the spread of Mpox. But just again, for the scope of this talk, I want to talk about vaccination as prevention because there are some relevant updates. So ACIP recommends a 2-dose Jynneos. Remember, this is the modified vaccine anchor, or MVA, non-replicating virus vaccine for people at risk of Mpox during an Mpox outbreak. So that's been approved as of February 2023. We were talking about this before that. And then who counts as potentially at risk or who might benefit from vaccination? I listed the criteria here. So people who were affected in the initial phase of the epidemic, persons who are sex partners of those persons, and people who anticipate experiencing any of those scenarios. So you can see that that's pretty broad. And I think many of us, especially now that there is no longer a vaccine shortage, or more recently has not been, we've been pretty, I think many, especially at Madison Clinic, have been interpreting these pretty liberally. So if anyone asks for the vaccine, we've been giving it. Is it effective? I think now we can say yes. We have really nice data, and this is a table that Jason had made that we used to kind of inform our section in the STD curriculum, but looking at the studies that have really looked at, does vaccination help? 1 dose is effective, 2 doses is even more effective. How much more effective might be marginal, depending on which study you look at. And then there was another study that looked out of the California Public Health that looked at hospitalizations stratified by vaccination and HIV status, and in all groups having any dose of vaccine reduced odds of hospitalization. And people with HIV, there weren't enough people who had gotten 2 doses to comment on that in particular, but it did seem that 2 was better than 1, but at least any vaccination reduced risk. And then this kind of gets at this is a little bit of a clinical manifestation point, but I did want to bring it up in vaccination because it's thinking about infection after vaccination and or previous infection. So there were a few studies I wanted to highlight. One was a pretty small but global series of 37 individuals who had had either vaccination or previous infection and then were reinfected. And what we saw was that disease was less severe. So primarily solitary lesions instead of multiple, no deaths, 1 hospitalization, and severity scores were lower in reinfection and post-vaccination. There was a cluster in Chicago that involved individuals who had been vaccinated as well as unvaccinated. All of those who were vaccinated had self-limited disease, and those who were fully vaccinated were less likely to experience mucosal involvement. And here in Seattle, Matt Golden and the Sexual Health Clinic put out data looking at Mpox testing. They tested for Mpox in asymptomatic and symptomatic patients at Sexual Health Clinic. And people who were vaccinated were more likely to have asymptomatic Mpox than the unvaccinated. So for those who received 1 dose, they were 4.4 times more likely to be asymptomatic, and 2 doses, 12 times more likely. So the conclusion there being, in my mind, less severe or asymptomatic disease is associated with vaccination. And I'll also note that the Seattle data was controlled for calendar months. So there's a question of even when you have higher rates of Mpox in the community, controlled for that. This is still the conclusion. So vaccination, what's happening now? As ever, nothing is simple. And so as of April 1st of this year, Mpox vaccine is commercially available as an ACIP recommended vaccination. The vaccine is covered under Medicare and Medicaid and is anticipated to be covered by private payers. What does that mean functionally for us? So I included this quote from the operational planning guide that during the transition to commercial supply, providers may continue to access the HHS Jynneos supply as commercial availability ramps up. But by the end of the summer, or I guess midsummer, depending on how we define summer, HHS anticipates that requests and ordering of JYNNEOS will fully close, and this will all be commercially available. So I know that was a whirlwind and a little bit of a potpourri of what's new in Mpox, but I think the take-home points I have, though we're not at near the levels of the 2022 outbreak, Mpox continues to circulate at low levels within the US and worldwide. In the US, it continues to disproportionately affect MSM, Black and Hispanic and Latinx individuals. Clinical manifestations include severe disease in those who are immune compromised, although in others, it actually may be less severe in the context of vaccination. We do need ongoing investigation to assess clinical impact of medical countermeasures, and those investigations are ongoing. And vaccination of populations who may be impacted by Mpox remains a critical intervention with a specific lens on equity of distribution. And I think of that in particular as we acknowledge what's happening in the DRC. And so with that, I just want to acknowledge Jason, who if you ever hear him give a talk on Mpox or other subjects, he's great, and National STD curriculum.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.